Thank you.
Okay, we will start. We will be on time. I think Professor Arman is with us, and both Professor Yelakovic and Nana. Okay, so let's start with the effect of the metabolic syndrome on arterial system. And this is my favorite slide. I'm really using it in a lot of my lectures because I want to show you very clear distinction between arteries when we are young. Unfortunately, during aging and influence of different risk factors, our arteries become yellow and rough. And actually, the task of us physicians are to slow this process. Unfortunately, we cannot stop that, but we can really influence a lot with our non-pharmacological and pharmacological therapy. So just a quick reminder that 20 to 25% of adults in the world suffer from the metabolic syndrome. This percentage is unfortunately increasing in all countries. And just as an example, every year, 3.2 million people worldwide die from complications of this syndrome. And the prevalence of this syndrome is increasing and is directly related to the degree of obesity. Also to remind you that the major features of metabolic syndrome include central obesity, hypertriglyceridemia, a low high-density lipoprotein, hyperglycemia, and hypertension. But we will speak more about that in the future minutes. And unfortunately, prevalence increased with age. Increase in waist circumference is found predominantly in women, and fasting triglycerides more than 150 milligrams per deciliter and hypertension are more likely in men. So risk factors for this syndrome mostly are overweight, obesity, mostly central, sedentary lifestyle, aging, diabetes, coronary heart disease, and about 1/3 of MS patients have premature coronary artery disease. And you also have a lipodystrophy, both genetic or acquired, has severe insulin resistance. So this syndrome is usually asymptomatic, and a high index of suspicion is needed for diagnosis. So during examination, if you find in your patient increased waist circumference, increased blood pressure, lipoatrophy, and acetosis nigricans, that should alert you to search for other abnormalities. And other associated conditions in metabolic syndrome includes cardiovascular disease, type 2 diabetes, NASH, hyperuricemia, PCOS with the prevalence of almost 40 to 50%, and obstructive sleep apnea. Insulin resistance is associated condition, and it's also associated with a lot of different other risk factors. And IDF criteria of metabolic syndrome includes waist circumference more or equal 90 in males, more or equal 90 centimeters, and 80 centimeters in females. And we need at least 2 or more of the following conditions. Those are hypertriglyceridemia, low HDL cholesterol, hypertension, and fasting plasma glucose equal or more 100 milligrams per deciliter. So global cardiometabolic risk depends on, as we saw, mainly diabetes, type 2, obesity, and some other biochemical situation and conditions, and high blood pressure. And one big meta-analysis done 13 years ago showed that the patient with metabolic syndrome, they have enormous cardiovascular risk. Even without diabetes, this risk is very high. And this is already almost 1 million patients in 83 studies. And they show this risk is 2.35 for cardiovascular events, 2.4 for cardiovascular disease mortality, and 2.27 for stroke. So genetic factors, excessive dietary intake, and lack of exercise leads to the pathophysiological processes like insulin resistance, visceral obesity, HPL dysregulation, and atherogenic dyslipidemia. and they all causes the metabolic syndrome through a different pathophysiological process. Also, there is a clear correlation between abdominal obesity and increased risk of cardiovascular events. The HOPE study showed that if we increase the waist circumference, we will have an enormous increase in cardiovascular death, myocardial infarction, and all cause of death. Also, abdominal obesity is linked to an increased risk of coronary heart disease. And cardiometabolic risk is very dangerous, since the cardiovascular disease mortality increases with the number of metabolic syndrome risk factors. So we have so-called clustering of those cardiometabolic risk factors, and they are fitting like a puzzle. And this puzzle is very dangerous. Also, this article by Carly showed that there is a great dysfunction in coronary circulatory function in patients with the metabolic syndrome, which definitely show that it leads to the increased cardiovascular events. And if we want to summarize the previous slides, we have to say that the changes in microvascular structure and function in obesity, metabolic syndrome, have been shown to result in an overall imbalance between tissue oxygen delivery and metabolism in many vascular beds, including heart, kidney, brain, and skeletal muscle. A hallmark of this syndrome induced vascular disease, because we have impaired endothelial function, which is associated not only with the diminished bioavailability of nitric oxide, but also increased production and the vascular sensitivity to endothelial-dependent vasoconstrictors, such as endothelin-1, prostaglandin H2, and thromboxane A2. So MATS is also associated with alterations in the functional expression of and electromechanical coupling between voltage-dependent potassium and calcium channels. Now we go back to the clinical part. So we now had the introduction, what is the link between metabolic syndrome and cardiovascular disease in pathophysiological sense. But how we can measure that? We can measure that through the arterial stiffness. I'm talking about arterial function. Arterial stiffness is an independent risk factor for cardiovascular morbidity and mortality when measured with the pulse wave velocity, and it increases with age, hypertension, and diabetes. And you can see in this slide that arterial stiffness is very related with pre-diabetes and metabolic syndrome, in sense that the metabolic syndrome through endothelial dysfunction increase arterial stiffness very early in the patients with metabolic syndrome. Also, if we see on the left are brachial artery, femoral artery, and carotid artery, all of them has a much greater arterial stiffness in patients with diabetes and metabolic syndrome. And you can see the pulse wave velocity and the velocity itself are mainly disturbed and dysfunctional in the patients with metabolic syndrome. The other marker of arterial function, very recently used and very good marker, is the cardioankylosing index, so-called CAVI. And the CAVI is a new marker of total artery stiffness from the aorta to the ankle. And the characteristic of this index is the independence from blood pressure at the time of measurement and high reproducibility. This is how we measure CAVI. And in the latest research, there is a very clear correlation between CAVI and the prediction of cardiovascular events, not just in the acute coronary syndrome, but in patients without cardiovascular disease, in patients with peripheral artery disease. So the group of authors from the International Society of Vascular Health, we did a very big study, multi-center, multinational study, so-called AAA study, where we showed actually by measuring with CAVI and other devices the effect of metabolic syndrome on arterial function in different age groups. And this study showed very clear correlation between age and arterial stiffness, both pulse assessed with CAVI or the pulse wave velocity done by other devices. And actually, I want to show you, because of the lackage of time, the summary of the main results. We showed that glycemia and blood pressure are powerful determinants of arterial stiffness. Then high triglycerides and low HDL have a modest or no effect, and abdominal obesity is negatively associated with arterial stiffening. And the effect of metabolic parameters are less pronounced in older persons. And very important conclusion is that the treated patients for diabetes and hypertension have increased arterial stiffness, even if glycemia and blood pressure are controlled by treatment. So this is the effect of time. And before I conclude, I would like to show two slides, very important, because the COVID is coming back to the future, like this film. And there is a very clear correlation between COVID-19 virus and its effect on patients with metabolic syndrome. And you have very dangerous endocrine immune vascular interaction shapes in clinical course. And unfortunately, COVID-19 cardiovascular outcomes are very bad in patients with metabolic syndrome. And we should manage those patients in a specific manner, giving them more attention and more intensive treatment during COVID, and especially in the post-COVID and long COVID. In the end, I would like to thank again the organizing committee and Professor Kotsis, and say that there are worse things than being fat, and one of them is worrying about it all the time. Thank you.